Case study number 12, presentation, a diagnosis of delirium, presented by Hamda Awaal. Objectives: definition of delirium, description of the case, correct diagnosis of the case, the rationale for the diagnosis, evidence and treatment plan, presentation of evidence and recommendation, and references. The definition of delirium. Delirium is an acute deterioration of cognitive functioning and is considered a medical emergency as it is often the result of anoxic disruption of the brain equilibrium. Delirium is common in hospitalized older adults, with some study reporting indicates rate of 29% to 65% of patients, mostly adults and elderly. There are three criteria of the diagnosis of delirium, and they are disturbances of consciousness, change in cognition such as memory deficit, disorientation of language, disruption with an accelerated change in a few days or weeks. Description of case number 12. The above definition and disturbance presented in the case study of 63-year-old Mr. Brown, as he showed serious neurological changes, with his CBC and CMP lab results indicate normal results. Blood alcohol level and head CT scans were also negative. In the case study, Mr. Brown had a medical history of coronary artery bypass 5 years ago. He had exhibited symptoms of urinary retention, madrassi with sedation, which befits the above description. He appeared to be taking daily prescribed opiates for his chronic back pain in addition to benzos, based on the toxicology report. Although the result was silent on opioid detection, it did not detract the strong indication of daily use. He appeared confused with waxing and waning alertness, was restless and agitated, but denied suicidal or homicidal ideations, and was very accusatory. He also denies any auditory or any visual hallucinations. His MMSE screening was very marginal. The correct diagnosis for this case is delirium. The rationale for the diagnosis. Since polypharmacy presented itself in the case study, the combination of opioids and benzodiazepine can cause delirium based on diagnosis criteria. Also, the patient had a couple of weeks exhibitions of uncharacteristic behavior before being found down. Using the screening tool of I Watch Death and delirium, Mr. Brown is diagnosed with delirium by screening the background history provided in the case study. Mr. Brown's delirium may have arisen from polypharmacy with possible drug-drug interactions and dehydration leading to urinary retention and possible infection as a result of the above. Evidence and treatment plan. Non-pharmacological treatment recommendation for Mr. Brown. Primary prevention is the cornerstone of delirium management, which is evidence for success of any intervention. Address common contributory risk factors such as cognitive impairment, sleep deprivation, immobility, visual impairment, hearing impairment, and dehydration. Strategies to include management of pain, maintaining nutrition, and performing a thorough medication review will be helpful in Mr. Brown's situation. The importance to resolve any urinary tract infection or any underlying illness. The need for one-on-one reorientation with Mr. Brown's family members to help with management and understanding aggression or severe agitation for the safety of the patient and others. Continuation of evidence and treatment plan. Pharmacological treatment recommendation for Mr. Brown. Typical and atypical antipsychotics may be considered for the management of delirium, even though there is an inconclusive evidence that antipsychotic use reduces delirium severity and duration. Others include benzodiazepine, but will not be appropriate for Mr. Brown in this case, and therefore not recommended for the treatment plan of Mr. Brown. Antipsychotics medication should be tapered gradually as Mr. Brown's symptoms continue to improve, as these medications should not suddenly or abruptly be discontinued during therapy. Presentation of evidence. Article 1. Topic: delirium in older adults, diagnosis, prevention, and treatment. The purpose for this research is to clinically explain the disease process of the delirium in hospitalized old adults and how to recognize it promptly, manage the underlying causes. The sample information was gathered from a critical care patient. The statistical significance indicated delirium may be due to an inflammatory mechanism and the cholinergic neurotransmitters deficiency in the brain. During acute illness, older patients are at risk of delirium due to the decreased cognitive reserve. The authors also recommended delirium is considered as a quality indicator in the care of hospitalized patients. A better understanding of the pathophysiology of delirium and some effective strategies for diagnosis, prevention, and management can help clinicians to ensure that patients affected by delirium receive the care they need. Presentation of evidence, Article 2. Topic: preventing delirium. Should non-pharmacological multi-component interventions be used? The purpose of the research is a study exploring the efficacy of multi-component interventions in the form of non-pharmacological strategies in preventing acute incidental delirium in the elderly patients in hospitals. Sample formation, 7 pooled trials were used. Statistical significance, a combined literature revealed that the multi-component interventions were very effective with incidental delirium, but had no significant reduction in delirium itself. The authors then recommended that included multi-component interventions should be maintained as effective measures in reducing incidental delirium, and accidental falls should also be maintained as a standard of care for the elderly in hospitals and other facilities. Presentation of evidence, Article 3. Topic: melatonin receptor agonists for delirium prevention. The purpose of the research is to analyze the prospective controlled trials available for melatonin receptors agonist use for delirium prevention. Sample information, 5 randomized and 1 non-randomized prospective were used. Statistical significance, the cumulative of randomized and non-randomized clinical trials demonstrated benefit to melatonin receptor agonists for delirium improvement in the patients, but inconsistent with prevention. Therefore, the authors of this particular research indicated melatonin showed conflicting findings with the most recent randomized controlled evaluations. The authors stated clinical trial data shows support for melatonin preventing delirium, but their current study showed no benefits. Therefore, the use of melatonin receptor agonists for delirium prevention could not be recommended at this time by these researchers. Presentation of evidence, Article 4. Topic: characterizing and predicting rates of delirium across general hospital settings. Purpose: the objective of the study is to categorize delirium frequency rate in terms of facility services and the primary receiving diagnosis of the patients with delirium. Sample information. The research collected total admission sampling of about 831,000 plus cases from 2 hospitals in 9 years to complete the study. Admissions were ages 18 and above. Statistical significance. The study determined that in both facilities, the rate of delirium in the neurological patients was higher than other variables. They also concluded that delirium was widely spread across both hospitals regardless of units of care and the diagnosis groupings. The authors therefore suggested that the findings possible target interventions for sample and readily available clinical features that predict the risk of delirium. This approach can lower the barrier for appropriate focus efforts of delirium recognition and prevention. Presentation of evidence, Article 5. The topic, the diagnosis of delirium superimposed on dementia, an emerging challenge. Purpose of the article, critically review vital elements of diagnosis of delirium superimposed on dementia, known as DSD, which is delirium in patients with dementia. Sample information was gathered from the DSM-5 and the International Statistical Classification of Diseases and Related Health Problems. Statistical significance. The researchers indicated these diagnostic criteria did not provide guidelines specifying the assessment test for evaluating cognitive process impairment in the delirium population. That brings about the challenges in diagnosing delirium on dementia. Therefore, they suggested a clinical examination, laboratory testing, and neuroimaging to do that diagnosis. Authors' recommendation offered a framework of a standard and a reliable reference to improve the ability to clinically diagnose for DSD as a clinical syndrome that may result in poor outcomes, including death. They also added a compounding challenge in the lack of accurate identification markers and sufficient assessment tools to diagnose DSD. Presentation of evidence, Article 6. The topic, the delirium and the population health informatics cohort study protocol, ascertaining the determinants and outcomes of delirium in the whole population. Purpose of the research is to explore the difference between incidental delirium investigation and cognitive impairment in aging process on older patients. They also had an objective to demonstrate any association with incidental cognitive impairment and the cognitive decline concerning the prospective impact of delirium on the long-term aging process. The sample informations were gathered from two different groups of elderly patients, one 70 years and above and the other 65 and above. The participants were recruited from 39 general practitioners and nursing homes. Statistical significance. The study was able to measure the effect of delirium was consistent with other studies. That primarily indicates that incidental delirium has been associated with the changes in global cognitive scale. Delirium is in an older individual due to aging process, overall has a higher mortality rate than other neurological situations. Therefore, the authors recommended a systemic characterization of a temporal pattern of acute illnesses and hospitalization causes delirium and other cognitive outcomes. The writers also reiterated how the underlying dementia influences the incidence and detection of delirium. And they also added that dementia, being a greater understanding of the progression of cognitive impairment in the aging process than delirium. This slide is the first slide for references. This is the final slide and the second slide for references. I had a total of 10 references to bring this presentation titled The Case of Delirium. I hope it was educative, informative, and hope you all enjoyed my presentation, and thank you.